Welcome everybody to Langstein Presentations. My name is Ira Langstein and I'm a restorative dentist up in White Plains, New York. I'm going to be sharing a series of restorative implant cases with you every few weeks. It's going to be a great conversation. I'm going to leave my email and contact info up here and we can start a great discussion. Remember, knowledge is a virtue. Let's look at this week's case. Now, these are congenitally missing lateral incisors, something we face all the time in our practice. We have to remember to think differently. You'll see on the screen my email is iralangstein@mac.com. Now, many of us face the conundrum of a patient coming in late in orthodontics, missing lateral incisors, ready for implants. And we're presented with something that I call the orthodontic stalemate. And what this means is the ortho is non-ideal. The orthodontist has not engaged us, the restorative doctor or the surgeon. It really becomes a treatment planning mess, and we have to search for an answer here while the patients are fatigued and the family's tired. They really want to get on with treatment. But there's a lot of issues, namely that we're missing bone. Many times the bite is open. Aesthetics are non-ideal, yet we're called on to perform a miracle here, and the patient is leaving for college or away at school, and the logistics are a nightmare. So what do? Let's look what we did here. First thing we need to do is really look at the challenges that we're facing. Now, in this case, the orthodontist did not coordinate any treatment with us. That's very difficult. Sometimes we're introduced to this patient late in the orthodontic chain, so we didn't really have control over the occlusion or the spacing. Surgeon has no idea what's going on. Sometimes there's an anterior open bite or the bite's too deep. Many times, if not always, we're lacking in tissue, both bone and soft tissue. And this is because there were never teeth there to begin with. So no teeth, no bone. And that's an issue because many of these patients don't want to undergo block grafting, and we don't want to put them through that. That could add years onto their treatment. There's a lot of morbidity associated with it, not to mention the logistics as well. And, we look at this with a perio probe, we start to measure it horizontally, and we're not really even sure if there's enough room for an implant. So many times we're boxed into a very small implant, if at all. So we have to really embrace a different type of an approach to a case like this in order to succeed. Let's look at what we did. The patient is breathing down our neck. They're really upset. The case has been going on for a long time. We just got involved. Everybody's disillusioned. Orthodontic options are off the table, and we have to do something. So let's look at our solutions here. In order to fix this, in order to get to the result we want, we have to embrace a digital workflow. That's crucial. I'm going to talk about that. We have to team up closely with our surgeon. We have to be hand in glove here. We can't really do this type of work unless everybody knows what's happening in the workflow. Have to match up expectations with the patient's family. We have to be flexible. We may have to cement these crowns rather than do screw retain based on angulation. Small implants don't have many angulated screw options. It's a very narrow space. We have to, talk to the family and say, listen, this is what we came in with. Here's what we're going to try to end up with. So we want to try to under promise and over deliver. And we have two things to do, only two to plan. Gather the data, right? We want to take photographs, obviously, but we're going to do a cone beam, either us or the oral surgeon, and we're going to do a clinical scan, which provides STL files. We're going to provide the surgical guide. This is something the restorative dentist needs to do. Actually design and provide the surgical guide. It gives us complete control over the case. The surgeon will place, we will restore. So here's how it works. In this case, we're using the Trios 3-shape to scan. That provides the STL files, and we're getting a cone beam. Keep in mind that neither of these modalities are useful by themselves. The data has to be merged, the STL and the DICOM images of the cone beam. So how do we do that? There's a few options we have to transfer that data. We could do it ourselves with a software such as Co-Diagnostics. Our surgeon could do it if they're so inclined. Other options are to send these files out to a third party. One is Smile in a Box, and they will merge it and set up a plan for us. We can actually enlist our local laboratory if they are digitally inclined and actually understand the workflow that's going on. And when this is done, what we get back is a marvelous detailed plan. And as a restorative doctor, we can appreciate the surgical limitations. It's hard to even imagine how a surgeon could place these implants without digital planning. But we can see that we're going with 2.9 millimeter implants. We tee up the case for our surgeon. we're ready to go. And out of this plan, we're actually generating a surgical guide. Now, keep in mind that even though we're setting this up for screw retained with lingual access holes, we may not get there because the implants are so narrow that the prime goal of the surgical guide is to get the implant encased in bone with the correct angulation. So the screw hole is going to be secondary. If we have to cement, we're going to deal with that. We look at the result, tremendous accuracy here. I don't think this case, and I think we'd all agree, could not be done without a surgical template. It's really impossible. And now let's get into the restorative phase. So many times these mini implants have two-piece healing abutments, and they're going to go ahead and create a decent emergence profile where we can restore from there without customizing it. We'll take our impression with our closed tray posts, and we could see our abutments being placed. These were placed with a placement jig, zirconia abutments torqued in, titanium inserts, and then we get our final restoration. And our final restoration that we see here are basically zirconia crowns, and they're layered with aesthetic ceramics. So it's a nice result. It's not a perfect result. We really didn't replace the missing bone. We're in a situation here where we had to deal with what we had to deal with, but within a few months, we're able to restore this before the patient is off on his way to college. So let's sort of review exactly what we did here. We can see the before, the teeth are lined up, moderately successfully. It's very hard to envision this, but we digitally planned the case. We're able to get some nice abutments in there, 2.9 millimeter implants with the digital workflow. We fabricated the surgical guide, we merged the data, and we're able to get into our result here. So this is what I wanted to show everybody this week, how to take a very challenging situation, simplify it, get the communication correct, get the digital workflow together, and get a result that we could all be proud of, and the patient was very satisfied. So thanks, everybody. I really appreciate it. And this, our first lecture together, and we're just going to do these short little talks. You saw my email again, iralangstein@mac.com. We're going to place this up on YouTube with a YouTube channel. We'll probably be on other forms of social media as well. And I look forward to hearing you and seeing you all soon.